Today's session will be brought to us by Doctors Shelby Harris and Jason Ong. Dr. Harris will cover the overlap of mental health issues and narcolepsy, how to find a reputable therapist, what to do if you struggle finding a therapist well-versed in narcolepsy. And Dr. Ong will talk about interventions programs coping and reducing depression and anxiety. My name is Monica Gao, and I will be your host today. I am a founder and executive director of Wake Up Narcolepsy. I would like to thank our generous sponsors for making today in this series possible. Thank you to Avadel Pharmaceuticals, Harmony Biosciences, Orexia Therapeutics, and Takeda Pharmaceuticals. I will read this following disclaimer. Wake Up Narcolepsy seeks to raise awareness about medications and treatments for people with narcolepsy so that they can make better informed decisions for themselves and their families. However, Wake Up Narcolepsy does not endorse or recommend any medications or treatments or make any representations or warranties as to the content, accuracy, or completeness of the presentations. Wake Up Narcolepsy is not engaged in rendering medical advice, and if you have narcolepsy or think you might have narcolepsy, you should consult with your doctor to fully investigate treatment options to meet your individual needs. And with that, I will introduce our two speakers and turn it over to them. They will each present, and at the end, there will be time to ask questions and have them answered by Doctors Shelby Harris and Dr. Ong. We have turned off the chat function, so please be sure to put your questions and answers through the Q&A feature at the bottom of your screen. Dr. Shelby Harris is a clinical psychologist and sleep specialist in private practice in New York. She is board certified in behavioral sleep medicine and treats a wide variety of sleep, anxiety, and depression issues using evidence-based non-medication treatments. Her self-help book, The Woman's Guide to Overcoming Insomnia, Get a Good Night's Sleep Without Relying on Medication, was published in 2019. Dr. Harris holds a dual academic appointment as clinical associate professor at the Albert Einstein College of Medicine in both neurology and psychiatry. Before going into private practice, she was the longstanding director of the Behavioral Sleep Medicine program at the Sleep-Wake Disorder Center at Montefiore Medical Center in New York City, New York. Dr. Harris has been an invited columnist for the New York Times Consults blog and is frequently quoted in the media, including the New Yorker and Washington Post. She has appeared on the Today Show, Good Morning America, and CBS Mornings. Dr. Harris can also be found on Instagram at SleepDocShelby, where she provides evidence-based information about sleep wellness and sleep disorders. Before I turn it to Shelby, I will introduce Jason. Dr. Jason Ong is the director of behavioral sleep medicine at Knox Health and an adjunct associate professor in the Department of Neurology and the Center for Circadian and Sleep Medicine at Northwestern University. He received his PhD in clinical psychology from Virginia Commonwealth University and completed his fellowship in behavioral sleep medicine at Stanford University. Dr. Ong's primary research interest is developing and testing non-pharmacological treatments for sleep disorders, including mindfulness, meditation, and cognitive behavioral therapy, CBT. Additionally, he has investigated the impact of sleep disturbance on chronic health conditions, such as migraine, headaches, and mood disorders. He has received research grant support from the National Institutes of Health and the American Academy of Sleep Medicine. Dr. Ong is also a licensed psychologist and a diplomat in behavioral sleep medicine, delivering behavioral treatments for insomnia, PAP adherence, and coping with hypersomnia. With that, I will then turn it over to Dr. Harris, followed by Dr. Ong, and we will open for Q&A after that. Thank you.
Thank you. Thank you for the introduction, Monica. It's a pleasure to be here. I'm going to share my slides. I've been working with Wake Up Narcolepsy for pretty much a decade now, so I love working with this organization. It's really a pleasure to be here. Let me get my slides. 1 second. Share screen. 1 minute. Almost there. All right, I'm assuming everyone can see this. If you can't, just let me know. All right, so I was tasked with talking today about narcolepsy and mental health specifically. And my overall goal really today is to just talk about some of the general diagnoses that we see a lot in narcolepsy that overlap mental health diagnoses, and also to talk about, Monica had mentioned, how to find a provider, because that's often the thing that I hear about most is that people really don't know who to see for support, who understand what it's like having narcolepsy or supporting someone with narcolepsy. So, as many of you who are here, I'm sure know, narcolepsy is a disorder that affects about 1 in 2,000 people. It has a significant impact on daytime functioning. And all these things that we see here, the excessive sleepiness during the day, the broken nighttime sleep, for cataplexy for many people. We have sleep paralysis, the hallucinations, vivid dreaming, automatic behaviors. That's a lot of the symptoms that we see with narcolepsy. And then because of those symptoms, a lot of times we see issues with accidents, sexual dysfunction, cognitive issues. The brain fog is a really big one we hear a lot, coping difficulties during the day with work, social, occupational, educational struggles. It really does impact, for many people, many areas of their lives. And when we think about treatment for narcolepsy, there mostly traditionally has been very pharmacologic methods to really treat narcolepsy, but more and more over the years, and especially in the past 10, 15 years, we're really trying to do more and more behavioral interventions to work alongside those who are on medication or instead of medication. And a lot of the behavioral interventions, as well as medications too, do address both the symptoms of narcolepsy, and we want to work on addressing any of the co-occurring mental health issues. So when it comes to narcolepsy and mental health, there's a significant relationship between the two issues, but it's not always super well understood, especially for certain issues. They can often coexist. And then what we find a lot, and I'm sure many of you have experienced this, is that there can be a misdiagnosis a lot, or it just is often labeled as just a psychiatric issue, and not the narcolepsy isn't initially caught because there really isn't a lot of sleep training and psychiatry training programs. Although that is slowly changing, it is a thing that many patients do report, just the misdiagnosis before they actually get an accurate diagnosis, or just part of it's missing, the narcolepsy issue in the diagnosis. And then misdiagnosis for a psychiatric disorder alone has been shown to lengthen the time to a proper narcolepsy diagnosis. So what I'm going to talk about, as I said, is the common psychiatric disorders that we see, and then how to find someone. So the common things that we see a lot are mostly depression. That's the biggest thing. But then anxiety, schizophrenia, eating disorders, and just going to go through some of the symptoms of those issues and help you to realize if it's something that you're struggling with, or someone that you know, a loved one who's struggling with, and when you might want to get treatment. So depression and narcolepsy. Depression is by far the most common mental health issue that we see in patients with narcolepsy. There's a big overlap between symptoms of depression and narcolepsy, and I have a slide on that. However, there has been research that looks at that when you take out the symptoms that overlap, there's still a significant depression in a number of people. And despite pharmacologic treatment of narcolepsy in some patients, they really do report for many significant issues with depression. Now, why is that is not fully understood. There are people who have suggested, is it a reaction to the diagnosis, acceptance issues? Is it a decline? It could be a combination of some of these things. We also see in people who have depression, there's a decline in participation in pleasurable activities. They don't have as much reward and mastery or accomplishment of things and that they used to enjoy. So they're not doing the things that usually give them some sort of accomplishment or pleasure in their lives, which can then further depression. And when you do those things, right, it becomes like this vicious cycle. You don't do things, it makes you feel worse. And then the worse you feel, the more you don't want to do these things. So when we think about just depression in and of itself, regardless of narcolepsy, you have to have one of these two symptoms. So it's either depressed mood and or a loss of interest in things you once enjoyed. And over the past 2 weeks, more days than not over those past 2 weeks. So think about that. If there's depressed mood most of the day, nearly every day, or loss of interest in things you once enjoyed going on most of the day, nearly every day the past 2 weeks, that might make you start thinking that maybe there's some depression going on as well. We also see in patients who are with depression, weight loss or gain, some change in appetite, change in weight, trouble sleeping, sleeping too much. We know that in narcolepsy, like I said, I have another slide that will compare the two. Then there's some, we call it agitation or psychomotor agitation, where you're physically agitated, moving too much, or the other side is moving too slowly. Excessive fatigue, tiredness in some patients. Then there's the feelings of worthlessness, guilt, hopelessness, decreased concentration, and for some people, thoughts of death. You don't have to have all of those other symptoms from weight loss down, but you need to have at least 5 of these 9 or so, and then have one of the top 2, that depressed mood and or loss of interest in things. And if that's going on, you might want to talk with someone about potential depression that's happening. Now, I love this slide. This was in Anne Marie Morse's chapter that she had written a paper looking at mental health and narcolepsy. And I love this slide because it's a really nice description of narcolepsy symptoms and depression side by side. And we can see with the narcolepsy symptoms, you have a much more sleepiness. Depression, there can be some sleepiness, but oftentimes with people who are depressed, there's a lack of energy and fatigue. Now, those can overlap, right? When someone has narcolepsy, they might be very sleepy and be fatigued. Sleepiness is when you're actually falling asleep. Fatigue is that lack of energy. We see a lot of that sleep fragmentation, and there can be some issues with fragmentation or maintenance or sleep difficulties in depression, so there can be an overlap there. In narcolepsy, we have the hallucinations that also can happen. Most of the time, they tend to be visual, sometimes multimodal, but more of the time visual. We see much more of that slow movement or agitation, though, in depression. There's also, we see, like I said, the sleep paralysis, the negative effect on school performance, weight gain, socialization issues. Those all can happen as well in depression, where you're withdrawing from people, you might have some guilt, and then appetite changes. So there is some overlap. But like I said, if you're feeling down, depressed most of the day, nearly every day, sad, or you're having a lack of interest in things you used to enjoy, like let's say that you might be too sleepy to do things, but you have the desire to do things, that's different. But if you don't have the desire to do the things that you used to enjoy, that's a sign that maybe you want to talk to someone about depression as well. So anxiety is another thing that we see in narcolepsy. It's not been studied as much as depression and some other areas. And when people talk about anxiety, it really there isn't like a one specific anxiety disorder that we talk about. It's a whole bunch of different ones. So when people think of anxiety, it could be a generalized anxiety where you worry about many things at once. It could be something like obsessive compulsive disorder, where you have obsessions about things. Do something. It doesn't have to be counting. It can be washing your hands. It can be do a whole host of things. Or you have some behavior that helps to reduce that obsession that's happening in your head. So that's obsessive compulsive disorder, social anxiety disorder, or fear of socializing with other people, or fear of judgment from others. And so you might avoid or white knuckle doing those things. So OCD and social anxiety are often seen, we do see that in patients with narcolepsy, but it's often, when we look at the spectrum of how it kind of starts, those tend to be there before someone might necessarily have narcolepsy, or they tend to overlap. What we do see in some patients with narcolepsy, though, and like I said, the research on this is pretty limited, but just in my own experience working with some patients with narcolepsy in this area, panic disorder, so fear of having panic attacks, and to the point where you're fearing having a panic attack because you've had a panic attack, or you're fearing having it, you're not doing things because you're afraid you're going to have a panic attack. So you might not exercise because you're afraid you're going to have a panic attack, or going on the train, or doing things out in public. And then simple phobias, so fear of certain things, a fear of dogs, fear of trains, fear of planes, whatever it might be. Those things we tend to see more after a narcolepsy diagnosis. The idea is that maybe there's a fear of loss of control that's going on. So I fear that I might not be able to, when it comes to a cataplexy or a sleep attack, those are things that people might start to fear, and then not want to do things more and more out of fear that those things would happen. And then what we also see is that a lot of the antidepressant medications that are used for cataplexy can address anxiety as well. So sometimes if something gets a little bit better, it's hard to tell, was it the chicken or the egg? What was going on, or were they just co-occurring? And you'll see that too. A lot of the time, some of the medications that we use for narcolepsy do also treat certain mental health issues. So we use a lot of like SSRIs, SNRIs, all these medications that can also touch depression, touch anxiety in some people as well. But you want to really be assessed properly to know what you're dealing with. Eating disorders is another area that we see a good amount in patients with narcolepsy. So they frequently report to be struggling with weight issues, being overweight, and there's a persistent craving for food. The idea is that it's potentially, one idea that's floated out there is that the disrupted nighttime sleep with narcolepsy is leading to ghrelin and leptin changes. And when you have more ghrelin, you actually become hungrier. So that's that craving for food, wanting food more and more. And what we can see in some patients, which I'll have a slide on, is binge eating issues in some people. And then there are some people with narcolepsy that actually have more anorexia, where they restrict eating, control eating, or bulimia, where they're binge and purge issues because of fear of weight gain. So if you find that there's issues around fear of eating or compensating for eating, whether it's binging and purging or any of that sort of stuff, it might be something that you want to talk with someone about. And when we see binge eating disorder, this is something that we see a good amount in some patients with narcolepsy, is that here's the criteria for it. So you need to have both. So it's not, a lot of people like to say, I had a binge, I binged on this, but when is it actually really something that needs addressing or to be addressed? Binge eating disorder is it's pretty common, and what it is eating within a 2-hour period an amount of food that's larger than what most people would eat in that period. It's very subjective in that way, but just a large amount of food. And then the other big thing is that you have a lack of sense of control over the eating. So it just feels uncontrollable, and it's a large amount. And then we also have to think about 3 or more of the following. So you're eating, for some people, it has to be eating rapidly. It doesn't, not everyone, or large amounts when you're not actually hungry. Feeling, eating alone because of fear or embarrassment that others would see, or then when you're done eating the amount of food that you're eating, feeling some disgust or upset with yourself, guilty, feeling down because of the behavior. So if that's happening at least once a week for at least 3 months, any of these symptoms, you might want to talk with someone about the binge eating aspect. And like I said, it's a separate thing from anorexia or bulimia, but this is something that we do see a good deal. Schizophrenia is the one other thing that I was going to talk just briefly about. So there's a lot of overlap in the symptoms between schizophrenia and narcolepsy, and I've seen a number of patients over the years who've been misdiagnosed as having schizophrenia because of the hallucinations. Doesn't mean that they can't both co-occur. They can. There are reports of it, but it's not as common, let's say. But it is something that people should keep in mind and advocate for. If you're someone who has a diagnosis of schizophrenia, making sure that it's its own separate thing, not necessarily the narcolepsy that is being misdiagnosed. So what do we see in schizophrenia? We see the excessive daytime sleepiness, but you can have mania in some patients with schizophrenia. There is definitely sleep issues. It changes. Narcolepsy is very fragmented sleep, but you can see that in schizophrenia as well. The hallucinations, you can have any kind of hallucinations in schizophrenia. You can have auditory, visual. We tend to see the most of auditory in people with schizophrenia, but not all the time. And then narcolepsy, what we tend to see the most are the visual hallucinations around sleep. So it doesn't have to be visual, but that's the more common kind of areas that they'll fall into. Cataplexy, we know in narcolepsy, catatonia, so it's a lack of responding, a catatonic kind of state. Sleep paralysis. It's interesting. We see a lot more periodic limb movements in both disorders. So rhythmic kicking at night, or restless legs, where your legs are very restless, or your arms before going to bed. So we see that in both issues. But really the hallucinations, the mental confusion, we see much more auditory hallucinations, mental confusion, we see a lot more in schizophrenia. So it's definitely something to think about if you have had that diagnosis, to really make sure that you are getting assessed properly and that there is not a confusion between the two. So when it comes to psychotherapy, what would a role for psychotherapy be? So a lot of people are in treatment for narcolepsy, and with their medical providers, their sleep specialists who are treating them. In some sleep centers, I was very fortunate to work at Montefiore for many years, and we had a wonderful narcolepsy program there under the tutelage of Dr. Michael Thorpe. And we had a very multidisciplinary program there. Very aware that that is unusual. Not a lot of places in the world have that. But when a patient would be in our center with narcolepsy, they would see Dr. Thorpe or one of the other doctors there for medication management. They saw me oftentimes for psychotherapy. And I would do before, which Dr. Ong's going to talk about much more of a formal research program that's being evaluated, and it's wonderful, CBTN. I did a lot of CBT for depression with many of my patients. So we focused on behavioral activation, getting them finding things to do, things, structure in their lives that gave them pleasure, a sense of accomplishment in things that they used to do that they don't do as much. We worked on a lot of solution-focused treatment strategies, social strategies, to help people feel some self-efficacy, feel validation in their lives. And then we also had a group program at our at the sleep center, which was absolutely wonderful. And that group program, I'll get to that in a second, that group program was fantastic because it really gave validation to a lot of patients. And the group program led by Meeta Goswami really helped when it came to social functioning overall for people. So we really try to think of people with narcolepsy and treat them from all different aspects, whether it's medication focused, but also working on mental health as well. And people really found it very useful. So, how do you find a knowledgeable therapist? That's really the biggest thing that I get asked all the time, because, like I said, at Montefiore, it's not common to have that kind of a multidisciplinary program that's happening, unfortunately. And I hope that that's slowly changing, or it's changing throughout the country and the world especially. So because most people, like I said earlier, people in graduate schools and medical schools aren't trained a lot in sleep disorders, let alone narcolepsy. So if you want to see someone, the best place, I'm skipping down to the bottom bullet point here, but the best place, in my opinion, to go is the Society of Behavioral Sleep Medicine, behavioralsleep.org. So if you go there and you find someone like myself or like Dr. Ong who has a DBSM, that's the key, then you know that you have someone who can do behavioral sleep medicine and is well versed in narcolepsy especially. There are a lot of people out there who say they treat sleep, but they're really more well versed in insomnia. There's CBT for insomnia. So there are a lot of people who do just that. So make sure you're working with someone who has experience working with narcolepsy. And when you see someone who has that DBSM, you know that they have been well trained, they have taken the board exam, or they've taken the exam to actually work with patients of not just insomnia, all different types of sleep issues using behavioral methods. The other thing too is if you really want to work more so on depression, other issues, eating issues, look for someone who has a DBSM but also has ideally a clinical psychology or social work, but ideally, a clinical psychology degree would be wonderful. So a PhD, a PsyD with a DBSM, you're going to have a higher chance of getting someone who is well versed in that. And now you can look, the other thing to consider is with telehealth, is that you can go online, and in many states, not New York yet, but we're waiting, there's something called the PsyPact. So telehealth has opened up access to care for many people. So if you go to that behavioral sleep medicine site and you see someone who is in some other state but looks like a great fit, look at that PsyPact site and use PSYPACT. And if you go there, it will tell you all the states that have this pact to work together. So you might actually be able to work with someone, in California, who could see you through telehealth. In the licensure for clinicians can get passed back and forth between the states. So it's a wonderful thing to do. And if you can't find anyone, or you need to go through insurance, and there's a limited number of people who would take insurance, ask the therapist that you're going to see to have consultation with someone who is well versed in it. So I do that all the time. I actually consult with MDs, PhDs, social workers who have patients that were recently diagnosed with narcolepsy, and I help them to get a better understanding of the nuances of the diagnoses, treatment ideas, and I'll be a consultant on the case. So that's another way to do it, especially if you have someone you've already been working with who you love your relationship, but you feel like there's a piece that they don't fully understand that's missing. So consultation is another great thing to do. And then, like I was saying, psychosocial support. A lot of patients frequently report difficulties interpersonally and need more peer support. So the other thing, Wake Up Narcolepsy, there are great places that have support groups that are super powerful, super beneficial. And I'm glad that we have more and more as time is going on. So education to the family, counseling, employers is really key. And groups are a great place to problem solve, to validate one another, and to feel like you have a community that fully understands. So in conclusion, and then I'll pass it off to Dr. Ong, be thoughtful about any potential concurrent mental health issues that you or your loved ones might be struggling with when it comes to narcolepsy and mental health. Like I said, there can be a lot of overlap, but be mindful of if depression is going on, if you feel like you're having more anxiety, obsessive thoughts, if any eating issues are going on. Don't ignore that mental health component. It is super important for overall health. So really think about talking to someone, and treatment is available, both medication and non-pharmacologic treatments. So don't ignore it. It's a piece of the overall treatment plan and really crucial for a lot of people when it comes to moving forward with their narcolepsy treatment. Thank you, and that's where you can find me. All right. Now I'll pass it off to Dr. Ong.
Get set up here. And thank you, Dr. Harris, for a really nice review on the mental health aspects of narcolepsy. Can you guys see the slides okay? I don't know if someone can
Yes.
give me a hint. Okay, great. Thank you, Monica. Okay, so I'm going to take the baton from Dr. Harris and talk about the psychosocial interventions for narcolepsy. I'm primarily going to talk about a program we've created that we're now calling CBTH. As you can tell, we're just adding letters behind CBT as we go along here. Let's see, here we go. Okay, so Dr. Harris did a really nice review about this, and I'll just do sort of a quick summary that right now our current treatments, primarily medications, can reduce sleepiness, but there's still this unmet need for other aspects, such as improving quality of life. People with narcolepsy, hypersomnia, reducing depression and anxiety. And the other thing that we're really finding, and I think Dr. Harris mentioned this, is that we need to find programs that really are relevant to people with narcolepsy, people who, therapists and providers that really understand what's going on with people with narcolepsy and how that might be different than just people who have depression and anxiety without narcolepsy. So the bottom line here, is that we felt there's really this gap, this clinical gap that we need to address with a psychosocial intervention for hypersomnia. So this is a study that actually was published about a year and a half ago now. This is what we call a treatment development study. It's sort of a if you build it, will they come kind of study. Because we had this crazy idea, but we didn't know if it would actually be feasible for people to do it. And, if we could get some kind of indication that this seems to be beneficial. So this is kind of a different type of study than what you might hear about a clinical trial. That's what I would call a confirmatory study, where you actually have a proven intervention or a drug. You've done some of the legwork on it, and now you're trying to see if it actually works. So this is really before we get to that stage. So I just want to share a little bit about kind of the program itself and give you guys a little bit of a taste of some of the things that we do. And I'll also show you a little bit of the results. So this project actually started before COVID. And luckily, we actually had the foresight to do this remotely. In part, it was because just logistically, we realized that in order to really have the widest outreach, we wanted to try to connect with people around the country. And so doing it remotely, we use live video conferencing. It was really the best way to try to do that. And as it turned out, one of the things we learned from the pandemic is that, yes, actually, telehealth works. So one of the wrinkles that we had in this study was to do this either individually or in groups. We weren't quite sure which one would be the best modality. So that was one of the few wrinkles that we put into this study. So CBTH, and let me just back up a moment and talk about CBT, because we use this term a lot, and I think sometimes it gets a little bit misunderstood because people, at least in sleep medicine, know about CBTI, and that is another form of CBT, but CBT really is a class of psychotherapy. So much like you have a class of medications called antidepressants, but there's different types of antidepressants. You have SSRIs, you have like MAO inhibitors, And they do some different things at the molecular level, and they affect different neurotransmitters. So the mechanisms are quite different. And in sort of a similar way, as an analogy, CPTH is designed very, very differently than CBTI. This is designed for people with hypersomnia. It has sort of different psychological mechanisms, if you will, whereas CBTI is quite different. There's also other types of CBT for depression, for anxiety. So just so you guys understand that CBT really is a class of psychotherapy, and CBTH is something that's really customized for people with narcolepsy and idiopathic hypersomnia. So in our study, we included both groups mainly because we felt that the psychosocial impact was quite similar to both of these. We understand that there are different conditions and there certainly are different features. And that's part of the reason why we made this program modular. The idea is that with these different modules, the clinician could pick and choose which one of these was most appropriate for the patient, whether it's someone with narcolepsy, someone with idiopathic hypersomnia. So that way you can further customize it. And this just shows sort of a table. This is probably more useful for someone with a clinical background, and just sort of our suggestion how you might roll this out to patients. But I do want to emphasize that the idea here is to make it modular, make it very adaptable and flexible so that you can best customize it to the patient profile here. So I just wanted to kind of give you some ideas of some of the techniques that we use. So one of the things that we do is this idea of structured waking. I know that's sort of a strange concept, but this idea actually came from one of our sleep neurologists that I work with back when I was at Rush University Medical Center. So her name was Dr. Margaret Park. And she used to tell patients with narcolepsy that, can you split up your wakefulness into smaller segments? And if we think about it, it's interesting. Most of us think about wakefulness as one continuous time period from when we wake up in the morning until the time that we go to bed. For most people, it's probably about 16 or 17 hours of continuous wakefulness. But if you're someone who has narcolepsy and maybe even someone who has IH, that might be too long of a time. And so, what we found is that if you could get people to maybe take this in smaller chunks, similar to the way that they teach time management strategies, which is part of the reason why this is called the Pomodoro technique. And this name actually came from a narcolepsy patient where they talked about using this technique to manage time. But this is what I mean by sort of a makeover of how you spend your waking hours. So the idea is we sit down and we talk this out with each patient just to get a sense of what their typical day looks like, what their lifestyle consists of, and we try to customize it to see if there's ways to incorporate some rest period. For some people, that might be taking naps. For other people, it might just be doing something they enjoy. Sometimes people with IH can't take naps because then they'll end up taking 3 or 4 hour naps. So again, this is very customized. And the idea is that we break it into smaller chunks so that it might be a more practical way of managing energy throughout the day. And then also in between, when you do have more energy, you might be able to be more productive. So this is one of the things that we do. And in addition to this, we usually use things like diaries. Sometimes we bring in alarms, even social support to kind of help people reinforce this structure. So this is an example of the what we call wake sleep diaries. In sleep medicine, we're used to saying sleep wake diaries, but in this case, we're actually more interested in what's going on during the daytime when people are awake. In this example, we just have it conveniently split up into morning, afternoon, and evening, but you can obviously customize this. Some people it's just 2 segments, some people it's 5. But this just gives you an idea, hopefully, of how we go about logging this. And the reason why we log this is just it gives people a way to keep up with it. We've actually tried to convert this into an electronic version. We were working on developing an app to do some of this stuff. So, this is just sort of the paper and pencil version. Another thing that we do is something that I borrowed from a program called mindfulness-based cognitive therapy that's actually designed to help people who have depression and depression symptoms. So that's another condition, as Dr. Harris said, where people may have a very low energy during the day. And so they do this exercise that they call the nurturing depleting exercise. The way that this works is that we get people to think about all the different activities that they do on a typical day. All right. Could be like getting out of bed, making coffee, making breakfast, brushing teeth. We get them to just write this down, and as create a level of details they want. For most people, they put somewhere between maybe 15 and 25 different activities. And then after they generate this list, we ask them to go through each activity and think about whether or not this activity is something that is nurturing. In other words, is it something that brings you energy? Or is it something that is depleting? In other words, it sort of zaps energy away from you, okay? Now, as you go through this, inevitably, you'll probably come across some activities that depends on how you feel, right? For example, like going to the gym. Well, on some days that could be very nurturing, right? You might go to the gym, feel really good about yourself, or go on a walk or go on a run, feel really good about yourself. That could be nurturing. Other days, maybe you don't have as much energy. You try to exercise, that could actually be depleting. So we realize that sometimes it could be both. In those situations, we just ask people to just think about what it is on a typical basis and just assign it an N or a D. And then after you go through this, then you count the number of N's and the D's. And so we then ask people to give us, usually have somebody talk this out. How many N's did you have? How many D's did you have? And what's your ratio of N's to D's? And what this does is it gives you an idea of where's your energy balance during the day. If you tend to have more N's, then probably you're having more of a nurturing day. You're getting more energy coming towards you. If you happen to have more D's, so if that ratio is less than 1, then you're likely going to be more depleted by the end of the day. Now this gives you a way to sort of think about what can you do to rebalance your energy transactions. So in some cases, we might talk about, are there ways to try to introduce more N's in your day? Sometimes that's possible. Sometimes that's not. If it's not, can you do fewer D's during the day? Because remember, that's a denominator as another way to kind of rebalance your ratio. And then, for those activities that could be an N or a D, depending on the day, then we talk to people about, how might you be able to approach this activity in a more nurturing way on a more regular basis? And sometimes that's a bit of a cognitive shift. Feels like kind of a Jedi mind trick, but sometimes the mind can be quite powerful. And if you can kind of align your mind as maybe another tool for this energy rebalance. So this is how we go through the nurturing depleting activity. Another big emphasis, and again, you heard Dr. Harris talk about this, is trying to help people with self-efficacy, self-esteem, and coping with their symptoms. So sometimes we do talk about like what it means to have narcolepsy or IH, what has changed. So just doing some processing. And a lot of times here, it depends on where people are in their journey. If it's somebody who has just been recently diagnosed, they may not have had a chance to really process some of this stuff. So we just kind of walk them through some of these things. And really, a lot of this is just helping people identify what's important to them. What are your values? And then can you still be someone with narcolepsy or IH who's still able to do the things that are important to you? Are you still able to live up to those values? So this was actually a quote from somebody that said, that they really were trying to be the person that they are, not who they were or who they want to be. So in a sense, it's just trying to bring you to the present moment and working with who you are now. And along with this, sometimes we talk about things like emotion-focused coping versus problem-focused coping. This is something that is done in psychotherapy, especially behavioral therapy. In other conditions such as chronic pain, we talk about riding the wave. So maybe on days where you have a little bit more energy, trying to just gently push yourself a little bit, not trying to exhaust yourself, but maybe you can do a few more things. On some of those other days where you don't have as much energy, maybe it's better to kind of pull back and see if you can rest a little bit more, recuperate, and try to get some of this stuff done on a different day. So this idea of riding the wave is actually a technique that's used in chronic pain sometimes. And then there's social support. So again, this sort of depends on where people are in their journey. Some have really not disclosed to others that they have IH or narcolepsy. In these cases, we try to make sure people really understand what the condition is that they have, provide some education if necessary, and that way they might be in a better position to explain what their symptoms are, what the condition is, maybe some of the underlying factors that cause narcolepsy and IH based on what we know now. In some cases, it might be helpful to provide some training on assertive communication. So assertiveness is being able to be direct with people, but not necessarily be confrontational or negative. That tends to fall under aggressive communication. So, there's a way to balance that where you can still communicate what you need to and draw boundaries without coming across impeding other people's rights or angering other people. And then information about disability accommodations, preparing for doctor's visits. So just making sure people have the tools that they need to effectively communicate their needs. In some cases, if they need to get some accommodations in their workplaces, we try to provide some guidance there. For those who haven't really disclosed to others and who want to, we talk about ways to talk to your family and friends. In some cases, it's just, kind of this idea of being assertive that it's okay to ask for help. Many of us don't really want to. We feel sometimes ashamed or, feel like if we ask for help, then, we're sort of waving the white flag, but that's not necessarily true. And a lot of times, friends and family actually want to provide some support. And then there is sort of the social aspects, especially in our study when we're providing these the intervention in groups, where people commented on how nice it is to meet other people who are going through a similar journey and to share their experiences with others who have IH or narcolepsy. Okay, so just to show you some of the data here, one of the things we focus on is depression. And again, as Dr. Harris mentioned, this is probably one of the most prominent comorbid mental health conditions. So we focused on that in this study. And on the left here is what's called the PHQ. So this is a very common measure of depression that just basically has a list of the depressive symptoms. And here we have the baseline, which is when people started the intervention, and then the post-treatment after they completed it. And you can see, like, for both the group delivery as well as the individual delivery, we got a nice decrease in the PHQ score. So this indicates a decrease in the depressive symptoms. In both cases, it was statistically significant, and the effects are what's considered medium to large statistically. Now, statistics are one thing, and in these studies that are considered treatment development or feasibility studies, it's also helpful to say, hey, can we have some kind of clinically meaningful reduction? So in the PHQ, there's a certain benchmark where if you get a decrease of at least 5 on your score, this has been validated to say it's something that is clinically significant. In other words, it has meaning to a clinician as saying, where a clinician would say, hey, you really have decreased your symptoms by quite a bit. In some cases, people may actually be in remission from depression. So our benchmark or our goal was actually to see if we could get half of our sample to have this clinically significant response. So it was a pretty lofty goal. And we actually did hit that with the group treatment. So it provides some indication that when you have that social support, maybe the delivery of our CBT components can be a little more effective. The individual is a little bit lower here at 30%. But I think just to give you some context, in a lot of other depression depression treatment studies, usually you're kind of in the 30 to 40% range in terms of like these clinically significant responses. So I think still, we stack up pretty well with other studies that are just aimed at people who have depression, setting aside narcolepsy. The other thing I wanted to show you as far as data goes is something called the PROMIS scale. So this is a patient-reported outcome scale that has been validated. It was developed by researchers for the NIH as a common measure across different disease conditions. And what I'll highlight here is this red box, this GSE. And as you can see down here, it stands for general self-efficacy. And this to us is very important because, our hypothesis going into this is that, if we could give people with narcolepsy and IH some tools to increase their self-efficacy, self-efficacy here is basically your sense that you can accomplish something, you can do something. In this case, you can live with narcolepsy, live with IH, and we feel that they're in a better position to help reduce those symptoms of depression, anxiety, and improve the quality of life. So we were quite pleased to see that, in this case, we got a what's considered like a medium, kind of medium to largish improvement here in self-efficacy. And it was really the one that stood out, even above and beyond things like changes in depression and anxiety symptoms, and even things like sleep disturbance and so forth. So this at least seems to be consistent with what we think, or the mechanism, in this case, the psychological mechanism of the intervention. Okay, I do want to talk for a moment about mindfulness. This is another area of interest for me and my research. And you probably know these different apps and programs. These are readily available out in the wild. Calm and Headspace, I think, are the two most popular mindfulness programs. It seems like there's a new mindfulness program coming out every day. And as those of you who are familiar with mindfulness probably know, there's several key elements. It's focusing on awareness, non-attachment, and it's really this third one, self-compassion, that kind of piqued my interest in terms of how it might be useful for people with narcolepsy. From some of our earlier studies, we had heard things about how narcolepsy affects their mental health in terms of the social stigma. People think of narcolepsy as being people who are lazy. They make fun of it. Some people are even skeptical it's a real condition. And so you get quotes. This is actually a quote from somebody with narcolepsy. I feel like people think of it's kind of a joke, and they're like, "Oh, that sounds great. I wish I had slept all the time." It's obviously not very sensitive. And then we've talked about the negative effect on self-esteem and self-efficacy. These quotes here: "I get tired trying to explain why I'm tired." And then I showed you this earlier. "I tend to focus on who I want to be, but I need to focus on who I am." So we were kind of curious to see if teaching people mindfulness could be useful. Now, this is usually taught in meditation. So, some people thought it would be crazy to try to teach people who are excessively sleepy how to meditate. But, we thought about different ways to do this, like with walking meditations, yoga, and so forth. So we actually got a study that was funded by the NIH. We call it the ASCENT study. It stands for Awareness and Self-Compassion, Enhancing Narcolepsy Treatment. So both in this study as well as our earlier study, one of the requirements is that people had to be on medications and standard treatment for narcolepsy. So in both cases, these are meant to be a complement or an adjunct to what you're currently receiving as standard treatment. So it's not meant to be a replacement for medication or anything. And then in this study, we actually tested 4 different doses, if you will. This is really like different durations of the study, because we weren't quite sure if people with narcolepsy could handle like the typical 8-week. That's what we have as a standard treatment here. We thought maybe shrinking it down to 4 weeks is one way to do it. The other would be to extend it to 12 weeks and have it kind of spaced out a little bit more, maybe shorter, shorter duration for each of the sessions, because usually these programs are about 2 hours per session. So it's a pretty long session. Right now, we're in the process of analyzing the data. We've actually completed our data collection. I did want to show you a little bit of quotes. So we do an exit interview, and Dr. Jennifer Munt, who's at Northwestern, who I've sort of handed off the reins to, she's kind of leading the project now. So this is some of the data that she actually reported at the sleep meeting that just concluded yesterday out in Charlotte. So I thought these quotes were really nice. This first one said, "I like the breathing meditation and compassion meditation because I feel like I'm hard on myself a lot. People with narcolepsy tend to be hard on themselves. It comes with the stigma people give us." This other person said, "I'm less critical of myself for sleeping and taking naps." And then this other person said, "It's hard to be easy on ourselves, especially when the symptoms are perceived as laziness. To just put a hand on your heart and say, hey, this is rough and you're not alone. It will be all right." I thought that this was really powerful. So I think that these, all 3 of these are very powerful quotes, and hopefully an indication of how people might have changed after receiving the mindfulness meditation program. So hopefully in the near future, we'll have our data analyzed. We can actually report some numbers to you to see how things worked out in our study. And just sort of a public service announcement that Dr. Munt wanted me to do. So she does have a follow-up study. I'm not involved with this, and I think this is aimed at adult family members and partners getting to try to get a little bit better idea of the social connection within families and support networks. And I think she has some ideas on how we might be able to incorporate that into some of our programs. So if you're interested in this, there's a link here. There's also an email that I think they've set up to learn more about this research. Okay, so now that I told you about some of the things that are in the pipeline, how can you get these? So unfortunately, right now, these aren't really available out in the wild, if you will. This is just done in research studies. But what can you do in the meantime? So again, I'm going to go through this pretty quickly because I think Dr. Harris covered a lot of this. Certainly talk to your doctor. That would be a good starting point. Let them know if you're struggling with mental health. Let them know if you need help coping. They should be able to provide referrals. Hopefully, if they know somebody who does behavioral medicine, if you're lucky enough to find a practice that has a behavioral sleep medicine provider, that would be great. Otherwise, hopefully they could, connect you. Ask to see someone in behavioral sleep medicine. I think earlier we gave you the sort of the code or the credentials or someone who is board certified in behavioral sleep medicine. Dr. Harris mentioned that there's telehealth options. And I just wanted to show you this. If you go to the website, I think that link was provided in the chat earlier, that the Society of Behavioral Sleep Medicine actually has a setup where you can just go and click on the state and see a list of some of the providers. As Dr. Harris mentioned, there is something in psychology that's called a SIPAC that now allows more of the interstate practice. So hopefully this will make these type of interventions more accessible. And the other thing I'll mention is that we've made our treatment manual for the first research study I showed you. We've made that available to anyone, any professional who wants it. So if you're working with a therapist, tell them about CBTH. We get requests all the time. I actually just got one yesterday. And I would say I pretty regularly get these requests. So tell them to contact us, and we're happy to send out the manual. So that way, they could get, they could hopefully read up on it, get some training, and be able to provide that to people who need it with IH and narcolepsy. All right. So with that, I'll conclude, and thank you very much for your time. And I think is it time for some questions?
Yes, excellent. Lots of questions coming in. Thank you, Dr. Ong and Dr. Harris. If you wouldn't mind stopping your screen share, and then I will pin you and Dr. Harris together here. Let's see.
Okay. Is it? It's not sharing anymore, is it?
No.
No, but you both
Okay,
are
good.
in the spotlight, and we can go through the questions here. The phone app, okay. Diana says the phone apps like Calm are totally free for those of us with financial issues, or are they?
Sometimes they offer Headspace, I know, for free at times. I don't know about Calm, but there's also like something like Insight Timer. There are a few that are free. So there are lots of different options out there that you don't have to necessarily have a monthly subscription for. Jason, do you know any others, Dr. Ong?
I think there's like Will. Yeah, I mean, it's again, I don't do anything with those organizations. They're companies, so they are for profit. But I think usually, even if they're not, like, the whole program isn't free, I think they do offer at least some meditations you can kind of get started with. So the idea is that if you kind of get your foot in the door, that's kind of their business model, you can at least get something. So it might be an opportunity to kind of start out there, see how it works, and in that way, if it's something that seems helpful, if you have the resources, and you can look into it or see if there's other programs. Yeah.
And the other thing too is that mindfulness meditation existed way before apps ever existed. So you can go to websites, you can go to, like, Mindful Magazine has great, they have a good website that has different exercises. There are things that you can do without having to rely on an app as well. I don't always use an app when I'm meditating, and I meditate every morning. So there are lots of different resources out there to try.
Yeah.
Thank you. Second one was, can you post that link in the chat, which I did. The Explain Study link is there. Yes. Rachel is asking, Dr. Ong mentioned that for the Ascent study, the mindfulness program was complementary to pharmaceutical treatment. Do you think CBT is always complementary to pharmaceuticals, or is the eventual goal to move away from pharmaceutical treatment?
That's a good question. I mean, I wouldn't say it's necessarily a goal. I mean, I think I would be in favor of whatever the best treatment is. I think in my opinion, it's probably unlikely that this will just be managed behaviorally. I mean, there is a biological basis to narcolepsy, and presumably to IH as well. We know less about that. So, I think I've often said that probably, the best thing would be to find a cure for narcolepsy. It would put someone like me out of business, but I mean, I'd be thrilled if we went out of business because people with narcolepsy had a cure. So, the idea behind this is that, until we get to that point, there's still this need. And maybe there'll still be a need even after that. There could be some long-term effects, but that's kind of the way I see it anyways. I don't know if Dr. Harris has any other thoughts
No,
or
I
her own
agree
thoughts.
100%. 100%.
Thank you. Somebody's asking if you know of any Canadian studies available for Canadians with narcolepsy to participate.
I don't.
Okay.
I don't know of any. Do you, Dr. On?
Not off the top of my head. I think that so I'll explain. This question has come up like, why is it just limited to the U.S.? And really, the issue comes from, at least when I was at Northwestern, that it was really hard to have international studies because our IRB only governs U.S. law. So
Yep.
it actually was not. We would love to include people from all over the world. This is actually more of an ethical regulation for the IRB. And to some extent, some other administrative stuff that if you start recruiting outside of the US, then there's like this big black box of like liability. So unfortunately, this is where some of that comes in.
Thank you. May is asking, and she's stating, I read in a paper that some patients' ADHD secondary to narcolepsy is resistant to treatment by, for example, Ritalin. I think that's my case. Do you have any tips on how to approach ADHD from behavioral's view?
I mean, yes, that ADHD is something that we do see in some patients, and behaviorally, it's definitely not my personal area of expertise. I always encourage people to, if they do think there's any sort of ADHD going on, I do encourage people to get neuropsych testing to know specifically what you're dealing with a lot of times, if you can. So that a lot of times neuropsychologists will have really good recommendations for what might be the best ways to deal with the ADHD, especially from a behavioral standpoint if you are treatment resistant. Dr. On, do you have anything?
Yeah, I mean, not much. I mean, I would agree. I guess the other thing is just conceptually, sometimes it's difficult because sleepiness itself could manifest in symptoms that are similar to ADHD, like particularly in kids. There's oftentimes misdiagnosis of ADHD where it's really some, excessive daytime sleepiness like narcolepsy. In some cases, it's untreated sleep apnea. So I think that, the first thing would be accurate diagnosis. And then after that, I would agree with Dr. Harris that, like getting connected with a neuropsychologist can help tease out like, what particular aspects could be effective, helpful.
Thank you. We have a few more minutes. I do have a question. If somebody cannot, has, joined or looked at the website to find a behavioral sleep medicine provider and just cannot get into one that is open, what recommendation would you have? And are there more providers, do you think, entering that space?
I think when it comes to more providers entering the space, there are definitely more and more people, a lot more than when Dr. Hung and I started out. So it's a growing field for sure. There's still a huge need though. So we need a lot more people, and we need a lot more people voiced or well trained in things besides just insomnia. So we're getting there slowly, especially with the narcolepsy space. If you can't find someone who's like certified in behavioral sleep medicine, which is a challenge, and a lot of us have very long wait lists right now, unfortunately. I think I'd mentioned it earlier. You can go to a provider who will be open. I think ideally someone who is probably going to be more CBT or ACT therapy trained, so might be better for you. And if they are willing to consult with someone like myself or someone who is well versed in narcolepsy, that'll probably be the next best bet to go. It's hard if you can't get in with anyone else.
Excellent. Thank
Yeah.
you.
I mean, I think
Long?
the other thing would just be, sometimes you can talk to like the nurses at the sleep clinic, or, there may be some other people that can at least give you a few tips and some strategies that can be helpful, and just to stay connected, I think is the main thing. Yeah, there is a shortage. That is one of the problems, to Dr. Harris's point. But yeah, I think, I mean, just based on sort of the volume of requests for CBTH and the interest, I think that, I mean, at least in the, what is it, like 20 years or so I've been in behavioral sleep medicine, I think this is definitely the most interest in hypersomnia I've seen. For a long time, it was kind of ignored because I think a lot of psychologists, didn't really know narcolepsy and didn't really want to touch it because it seemed too medical. So yeah, hopefully we can continue that trend and get more people interested.
Thank you. Two more questions. how would somebody coordinate giving your information to their therapist for, say, a peer-to-peer consult?
The way it usually works, at least with me, is that usually the therapist will reach out to me. So just like my website, you can go to my website, dr for Dr. drshelbyharris.com, and you can submit a request for me, or you can give the website to your therapist. If your therapist isn't open to consultation or talking with anyone else, then that should be a red flag to you. But usually therapists are often willing to reach out to me, or you can reach out to me too. But because of privacy issues and stuff, it's usually best to have you talk with the therapist and have them reach out to me with signed forms.
Thank you.
Welcome.
And let's see, how big are your studies? I think maybe Dr. Muntz, that maybe this is what she's referring to. Her daughter was diagnosed 2 years ago, has neurologist, and is taking armodafinil. Prior to med, she did not experience the auditory and visual hallucinations. Why is this?
So how big are the studies right now? Pretty small scale. Most of ours, as I mentioned, are these feasibility studies because that's oftentimes the first step. You know, the parallel would be like drug studies when they're trying to figure out safety and dosing. Those are usually relatively small studies because you want to try to work out some of these things before you run one of those confirmatory clinical trials. So yeah, so they're pretty small scale. And then, sorry, what was the second
She
part of
said,
that?
After armodafinil, the hallucinations, visual and auditory.
Oh,
I don't know.
yeah, I don't know. You know, I mean, that's kind of a clinical question. It's hard to answer unless you do like an evaluation. So yeah, I think, you know, check with the doctor to see, you know, that would be the best way to answer that.
Yeah.
thank you. One last one. Somebody's asking how we can get their, I think they can get their doctor's info on the CBT-8H, CBTH.
Yeah, let me see here. I will, see if I can enter this. I will put in my email address here. Did I get posted?
No.
If not, I can put it in the chat.
It's not posted. Oh, yes, it is.
Okay.
Yep, you're good.
Well, here, let me do it in the chat anyways, in case people want it. But it's just basically jasonong@northwestern.edu. So I'm actually just adjunct at Northwestern now, but I still have that email address. And as a heads up, like if you send something to it, you'll get this kind of cryptic auto response that says like, I don't really work there anymore, which is just mainly my way of being able to pick and choose who I want to answer to. So just say that you're looking for the CBTH manual or ask your therapist or whoever wants it to mention that, and I'll respond.
Good to know.
This was excellent. Thank you both very much, Dr. Harris and Dr. Ong. Such a wonderful amount of information coming through, and I learned something new every time, especially in this subject. So very relevant. Okay. Thank you very much.
Thank you for all you do. Thank you.
Appreciate
Yeah,
you.
thanks for inviting us and good luck, everyone.
Take care.
All right. Have a great evening. Bye-bye.